I'm Katie. I'm a general internist at UBC in our POCUS program. Did my training out at Western, like Brian. So I'm one of the Rob Arnfield's offspring. So this is a case from our POCUS service that we saw fairly recently. So I'll just kind of talk through the case. I had some interesting images, but this is essentially a 94-year-old guy whose only known cardiac history was AFib. He had this old echo on file that was fairly unremarkable, but a difficult study, and came into CTU with sort of a few months of functional decline as well as a GI bleed. And so we were asked to see him for hypotension on the ward, kind of pressures in the 70s, mildly hypoxic, not really, a hemoglobin in the 70s, and a bit of an AKI. So sort of did a full body scan here. And I'll just go through his images. So quickly, these are his lungs, which essentially looked not that exciting. So A lines in R1, B lines in R2. We're now sort of lower down on the chest in the midclavicular line for us. A few B lines here as well in R3. We're up in the axilla for us. And then this is PLAPS. This is his PLAPS view. So kind of a moderate pleural effusion. The left side looked relatively similar. So A lines anteriorly, a few B lines as we move lower down. We're in like the 4th or 5th interspace in the midclavicular line. Up in the axilla, a couple Bs, and then a pleural effusion at the base with some B lines curtaining in. His heart is a little more interesting. So this is his parasternal long axis view. So you can see it's a bit of a difficult view. It comes in and out. From what you can see of the LV, systolic function looks okay. Mitral valve looks like it's not, kind of a bit calcified, maybe not opening great. Aortic valve, maybe a little calcified, but opening reasonably. This is his apical 4-chamber, sort of the best available apical 4-chamber view. Again, kind of hard to see a lot of the LV. We're not really seeing any of the lateral wall there. The RV, certainly size from this view, and systolic function looks pretty reasonable. TAPSE visually looks okay. Does have some pretty impressive tricuspid regurg, obviously, severe TR, at least qualitatively, looking at that big jet. When you throw some continuous wave Doppler on it, appreciating that our angles are not optimized here, sort of the alignment's not optimized, gives you a pressure gradient of sort of 38, so probably some mild, at least, pulmonary hypertension. And then this is the color across his mitral valve. So interestingly, this sort of eccentric, anteriorly directed jet that, you know, it looks to wrap sort of all the way around the right atrium, or sorry, the left atrium there. This is his VTI, so his LVOT VTI, which is severely reduced at 11.5 in what is, you know, a reasonable view there. This is his IVC. This is a transhepatic view of his IVC. Subxiphoid views weren't available, so kind of hard to interpret. It looks like there's kind of some pinching right at the diaphragm there. If you look a bit kind of more distally, it maybe doesn't appear to be moving. But the short axis IVC, which I've started to do in all of my patients, I find quite helpful. So here it's quite clearly this sort of oval-shaped, non-plethoric collapsing IVC. In the setting of the very severe TR is somewhat telling, somewhat surprising. And this is, so we tried to vexus him. We couldn't get reasonable hepatic veins, but this is his portal vein, which is, again, kind of interesting. So even despite his severe TR, his portal venous profile looks fairly normal. There's kind of dropout in the middle there, which is just translation with respiration. But looking at the rest of this, you have this continuous low-grade portal venous profile, which I don't know about others, but of all of the vexus waveforms, you know, looking at the hepatic vein, the portal vein, the intrarenal vein for signs of venous congestion, if you're just going to do one, the portal vein is usually the easiest to interrogate and also the easiest to interpret. So in this setting, kind of another useful piece of data to show that this guy doesn't look to be volume overloaded, kind of despite his really bad TR. So I actually then posted on Twitter because we thought his valve was quite interesting because this is all new, right? This like severe eccentric MR, it was nowhere on his previous echo. So kind of posted this and crowdsourced Twitter wisdom in terms of what was the pathology causing this. And this is just kind of a reel or whatever, a video kind of showing a few shots of the valve. These were kind of the best images we could get. I sort of tried to zoom in and see better what was going on at the valve there, whether there's prolapse, whether there's flail. A couple people on Twitter very helpfully had taken the time to freeze the image and screenshot it and post it. And so I actually got some images, some replies that this was P2 prolapse, and some replies that this was flail. I mean, I think either one would give you this, a posterior leaflet pathology would give you an anterior directed jet. That kind of fits. Someone else also posted this. I mean, Twitter's so helpful, right? This very helpful graphic of, the difference between those etiologies. So to me, I don't know if I can tell enough from this somewhat blurry zoomed view to see whether that's truly prolapse or flail. I think in the end, it didn't really matter for this guy. Going back to the question we were asked was should this guy have fluids for his hypotension? As you guys all know, fluid responsiveness is a whole ball of wax and difficult to determine. And we've got an IVC view here that is collapsible, but the IVC is not very good for this. We did feel, so the VTI, we felt I think that's to me the most useful piece here. We felt that his low VTI, and so therefore his low blood pressure and shock was due to low preload. That was probably a combination of actual hypovolemia from hemorrhage and his GI bleed, and then also partly from not enough blood getting to the left side due to his severe valvular pathology. The latter part, obviously, we couldn't fix. But we did feel like giving him a trial of fluids, and in this case, blood, obviously he's got a GI bleed, would be reasonable. We also felt that, he's going to be at risk of congestion and volume overload with his valve disease, but, his right heart looks okay. His lungs don't look that bad. He's not that hypoxic, and his IVC looks okay. He doesn't have solid organ congestion. So we went ahead and gave him a unit of blood. And this was his VTI afterwards. So for whatever it's worth, and he did clinically look, respond with a better blood pressure. So his VTI did increase. This is just over 15%. So I guess technically is fluid responsive for whatever it's worth. In the end with this guy, it's a bit like rearranging deck chairs on the Titanic. This guy has a surgical valve problem. And he's not a surgical candidate given that he's 94 and extremely frail and all that. So I think cardiology ended up getting involved and didn't say anything very helpful. I think in the end, this guy was palliated. I think the thinking, or at least our thinking, is probably that he had degenerative valve disease, and then maybe either, had progressive prolapse or degenerative kind of a flail leaflet that had probably been going on for some time as the cause of his deterioration. And then the GI bleed was just sort of the straw that broke the camel's back in the end. So that's the case. I'll briefly, Brian always asks for an update on programs. I'll briefly just say that we're kind of growing here, which is really exciting. We have a ultrasound and procedures rotation that is sort of growing and increasing our footprint in the hospital. So we do diagnostic and procedural POCUS consults for CTU, but now also increasingly the hospitalists, palliative care, sometimes emerge or surgical services call us. So we're kind of growing, which was pretty exciting. We've had 2 fellows just finish with us this year. They each did 6 months. And then we've got 2 fellows doing sort of longer fellowships with us next year. And then a couple people also coming for some extra training. We're gonna be taking on med students for some trial electives. So exciting things happening here. So that's it. I don't know if people have thoughts about the case or want to share, but thanks, Brian.
Katie, can I ask you a quick case? Sorry, I don't know if it was just coming through glitchy on my side. When your peristernal lung, there's that anechoic fluid collection kind of just behind the left atrium.
Oh, yeah.
Was that just a massive coronary sinus, or what was that?
No, you're good pickup. So we looked at that, and that was actually also a point of discussion. Let's go back. This thing.
Sorry to track it back.
That is appendage, left atrial appendage. I'm pretty sure, having we went and we looked it up, and having looked at other pictures. And I was actually quite surprised because I don't know if I've ever seen it on a TTE that well before. Obviously, you see it on transesophageal, but I'm pretty sure that's left atrial appendage, which is
Yeah, I've never seen that. That's cool.
Mhm.
Thanks.
Yeah. Any other thoughts about what's going on with the valve? I mean, I guess it's a totally moot point whether it's flail or profile.
It's a really good case. I mean, I think that the thing is that this kind of patient with a transthoracic, like ultimately you need better clarity, and it would probably be like a just transesophageal, right?
Oh, totally.
Answer, but obviously, you know, probably wasn't in the books for this gentleman. But
Yeah.
you know, and if you thought that you know that they'd be problematic intubating, extubating, you might just intubate, you know, like actually work up for surgery, intubate, and then do the TE, decide ultimately from there. But
Totally.
I think both are plausible. I mean, I thought that probably was like myxomatous just based on age, plus like tricuspid and mitral valve disease.
Yeah,
Basically,
for sure.
you know, I've seen spontaneous ruptures of chordae just from myxomatous. So anyways, just here's my thought on it. You know, and certainly with the eccentric jets, like it's pretty impressive when you see on transthoracic, they may not look as impressive, but then on TE, you're like, oh, they're big. And it's actually one of the, you know, the cardiologists here often talk about litigation and eccentric mitral valve disease, eccentric regurgitation, because it's just so hard to assess.
Right. Yeah. No, but you make a really good point about the TEE. And I mean, I guess it's one of the things we struggle with on the ward, right? Like in the ICU, you guys are kind of spoiled. You can do all the fun things, right? But we get these not for intubation, not for ICU. No one's going to do cardiac surgery on. So it's trickier to kind of work with what you have on the ward in some ways.
Well, to be honest, we get that all the time. When we get with broncs too, because they're like, oh, like they sample or they want something, and it's like, well, is the price really worth it, right?
Yeah.
And so with TEs as well, but you know, it always comes back down to the patient. So if the price of finding out the diagnosis is not worth it, then that's it, you know.
Yeah.
Any other comments at all from anybody?
Can you guys hear me okay?
Yeah.
Yeah, it's Vic Chove in Kelowna.
Okay.
So the structure you guys are pointing at, I wonder if it's the coronary sinus. It can be quite enlarged. And when I did some congenital stuff, you know, and I told the attending in this view, you know, this, you know, is this the appendix? They're like, they laughed in my face. So I mean, I guess the way to really prove it would be to do a contrast.
Totally. To inject some contrast. No, because that was my first thought as well, Vic, totally, was that this was coronary sinus. And I feel like we normally see it there. And like, you know, then I started thinking like, oh, does he have some weird, like undiagnosed congenital heart disease? Because I remember from like my echo boards or whatever, right? You know, these questions about enlarged coronary sinuses and everything. At least from the Google images we pulled up, we did find a few papers where it looked exactly like this. And especially with that, what am I looking at? The like little, not septation or whatever there. We thought that this might be appendage, but you're right. We should have like shot some bubbles in to see, because that was my first thought as well.
Are you on the line, Sanam?
Hey, Brian. Yeah, I am. My first thought is this is probably coronary sinus. As you guys pointed out, you can certainly do some contrast to facilitate and see if this is indeed appendage versus sinus. I think ultimately it's a moot point though, but it looks like a coronary sinus to me.
Cool. Thank you.
Yeah, I've only seen the coronary, like I've seen the coronary sinus on like a apical 2 chamber because it's so anterior. So it really, we really have to wrap around to get to this inferior portion. So I think that certainly makes more sense. Okay, awesome. Well, unless there's more questions here, maybe we should move on to the next one.
Just one quick question. So do you guys typically, if you do see, if that is the coronary sinus and it is that dilated, in my mind, that's always considered abnormal, and either they got some congenital problem that hasn't been identified or they got high right pressures. Do you guys typically, is that kind of the general consensus you guys use as well, or?
Yeah, like I think it's certainly not normal to have that for sure, right? I mean, in this 94-year-old guy, our suspicion of something congenital was pretty low. Yeah, I think in the end, it, as was said, I don't think it would have changed management for this guy, but I think your point stands in that you would want to think about why it was dilated for sure.
There is pretty substantial tricuspid regurgitation.
Yeah,
It
of course.
could be like in the severe range. Like the waveform from the TR looked pretty triangular and dense. So that would be my suspicion for one reason. You go back and look at the atrium, like is it dilated, for example, other indicators of atrial overload. Any other ideas for coronary dilatation?
Yeah, probably just overload. That's usually the most common cause.
Cool. Okay. Well, who do we have next here? Let me just take a look at my, I think maybe it's Laz.
Awesome. Thanks, Brian. Thanks, Keith. That was a great case. Really, really interesting stuff. I've definitely never seen that before. All right. So this is a case that I'm going to present here. And before I present it, I'll just throw some shout outs as part of it. So my name is Laz. I'm the POCUS fellow here at the U of A, working under Brian and Vince and the team. And I apologize, there's going to be noise in the background because I'm actually at the Alex on Expo right now, and there's not a lot of space for this kind of stuff. So a big shout out to Jeff Odenbach, who is the POCUS wizard who found this case and actually did the primary scanning. Vince, who did the interpretation, of course, the Godfather, who supervises all of us and blesses us from above to make sure this happens appropriately. So the case presentation is a 40-year-old woman was admitted to ICU from peripheral hospital with hypoxemic respiratory failure and septic shock. She's a complicated lady, has a history of HIV with a CD4 count of 4 from 2 months ago, treated hepatitis C, a previous right subclavian artery injury with endovascular repair, a cesarean section, and she's COVID positive from 3 weeks ago. And the story is she was admitted to hospital about a week and a half ago with COVID-19 mild hypoxemia. She was treated with dexamethasone, sent home. She comes back into hospital after being home for 3 days with severe shortness of breath, pruritic chest pain, non-productive cough, pre-syncope, and severe nausea. She was in peripheral emerge, went up to get to the bathroom, and essentially collapsed. Pressure was 50/30. She was incontinent. She was very confused and profoundly hypoxic. So they aggressively resuscitated her, started her on multiple pressors, resuscitated her with crystalloid. And over the course of an hour and a half, 2 hours, she became hypoxemic, requiring a non-rebreather with nasal cannula on top. So she was emergently intubated and then transferred to our center because the peripheral hospital did not have an ICU. On the right side is her initial x-ray on arrival to our center. As you can see, there is an endotracheal tube in place, a right IJ in place. There is diffuse bilateral patchy airspace disease, worse in the bilateral lower and mid lung zones, but really with no spared areas of the lung. Otherwise, no significant pneumothorax or other findings on the x-ray. And so let's get to the good part. Investigations. White count was up, hemoglobin's a little bit low, INR is a little bit elevated with normal haptoglobin. Transaminases and bilirubin are elevated and CRP is quite high. And of course, our CD4 count confirms again non-compliance with HIV therapy. Creatinine lights are all normal. And then we sent off our microbiology, and we can see on the right side, our gas shows what looks like a metabolic acidosis with respiratory compensation, normal troponin. So, POCUS time. A POCUS of the heart, lungs, and abdomen was completed. This is in the setting of shock, hypoxemic respiratory failure, and then this elevated bilirubin / transaminases. The transthoracic echo showed normal biventricular function with an LV estimated function of approximately 60%. There were no obvious regional wall motions. There was no diastolic dysfunction. There was no effusion. There was moderate concentric MR with no other valve abnormalities. The lung scan showed an A-line profile with mid and basilar B lines with consolidated lungs at the bilateral bases. This is in keeping with a pneumonia affecting the lower lobes, less like that atelectasis, and then trace pleural effusions. And then over here, we've got our abdominal scan. And so this is the right upper quadrant of the abdominal scan. So for those who don't do a lot of abdo ultrasound, that's liver, and this there's a structure that comes into view. Here you can see this is the gallbladder. So it is a severely thickened gallbladder wall with irregular wall enhancement and pericholecystic fluid. Okay, you can see the IVC kind of disappearing as this happens. This is not normal. So let's look at some more views here. When you see something weird, let's keep looking at it. So this is now the transverse view of the same gallbladder. And again, this wall is just immensely thickened, irregular, pericholecystic in nature. We're looking for stones and looking for sludge. And we don't really see any stones or sludge. The center is really anechoic, in keeping with the simple gallbladder fluid. And then, of course, this is just the completion of our fast scan. The bladder is full with a Foley catheter in situ. So now, what we see is that we have concern for what our findings are. So we have a diffusely thickened and edematous gallbladder wall. It's about a centimeter in thickness. There was no cholelithiasis and no sludge. There was pericholecystic fluid and no other ascites or soft tissue edema. This will become important in a second. The bladder is obviously distended. This is concerning for suspected acalculous cholecystitis. The diagnostic abdominal ultrasound that was done by radiology showed a thickened gallbladder, approximately 14 millimeters, with edema, but no luminal distension or gallstones. And then again, trace pericholecystic fluid. The opinion from the radiologist was this is more likely in keeping with passive causes such as third spacing, CHF volume overload rather than primary cholecystitis. And they said, need to rule out HIV-associated opportunistic infections given the history. Of note, when we look at our images here, we really had no other free fluid in the abdomen and no signs of anasarca or volume overload. So the concern kind of here with the opinion provided by radiologists that it doesn't accentuate enough the concern for severe septic shock in this otherwise critically ill patient. And so what is acute cholecystitis? So there's the sonographic findings for acute cholecystitis are as follows. You need 3 of the 4 to confirm the diagnosis: an impact the stone in the cystic duct or the gallbladder neck, a positive sonographic Murphy's sign, thickening of the gallbladder wall of greater than 3 millimeters, and we have a centimeter here, distension of the gallbladder lumen of greater than 4 centimeters, pericholecystic fluid collections, and then hyperemia of the gallbladder wall on color Doppler. And in particular, when we look at risk factors for acute acalculous cholecystitis, which occurs in 5 to 15% of our acute cases, we look at, in particular, major surgery, severe trauma, sepsis, the use of TPN, underlying history of diabetes, atherosclerotic disease, or HIV infection. This patient, of course, has multiple risk factors. And what I have here is just some images of acute cholecystitis from the literature. And you can see in the top left, can you guys see my, yeah, okay. So top left, you can see the gallbladder in a transverse view here with approximate measurement of the gallbladder wall. There is a small stone and then significant sludge in the gallbladder, as well as there is a stone in the neck. There is trace pericholecystic fluid, and then in the bottom, in the top right, you can see this is the use of color Doppler to further clarify the hyperemia of the wall. And then in the bottom left and bottom right, we can see the wall thickening with sludge and big gallstones. So this is classic for what looks like acute cholecystitis. And so in terms of progression of the case, the POCUS team communicated with the attending physician the concerns for acute acalculous cholecystitis. An ultrasound-guided cholecystostomy tube was inserted the same day, at which point about 15 to 20 cc's of thick bilious pus was aspirated. And the patient underwent C-tube insertion. At present, at that time of this case, the patient remains in the ICU with severe hypoxic respiratory failure and ARDS now post-admission day 14 with source control from this infection. The cultures that were sent from the biliary drain are still negative, and unfortunately, the patient was on antibiotics for a full 48 hours prior to this. So the likelihood of positive cultures is less, but again, not zero. And so just talking a little bit about acute acalculous cholecystitis, the pathogenesis of this process is that it results from gallbladder stasis and ischemia, or it can also be a local inflammatory response in the gallbladder wall. There are multiple risk factors on the right side that I won't highlight, but I'll just highlight two important ones: immunosuppression and acute and AIDS, and in particular, the presence of specific primary infections such as CMV, microsporidia, cryptosporidium can also increase the risk. If you have acute Acalculous cholecystitis, you're also at risk of secondary infections from enteric pathogens, including E. coli, Kleb, E. faecalis, the usual kind of suspect. And the treatment for this, of course, is essential. So any delay in treatment can increase mortality from 30 to 75%. Supportive treatment includes antibiotics and resuscitation, but the definitive therapy is either a cholecystostomy tube or a cholecystectomy, and that's depending on the algorithm on the right side, which is taken from month to date. And so in this patient who was critically ill in the ICU, the next step was a C tube prior to assessment. And so to summarize this, the patient underwent a point of care abdominal exam, which identified a critical pathology. We conveyed information to the most responsive physician rapidly and improved timeline to interventional treatment. And we further clarified not only the diagnosis, but also assisted with resuscitation in terms of the echo as well as the thoracic ultrasound, which then clarified the hypoxemia and the shock. And with that, I'll wrap up the case and ask if there are any questions or comments.
I think it's a really good case, Laz. It's interesting, how ultrasound has really enabled us to assess these organs like at a much higher frequency, and it becomes hard to ignore them sometimes. And I think the radiologists often point out, as you say, kind of anasarca and ascites, which often confound assessment. But it's interesting when you find it, you really have to push yourself over the line, right? Because if you got the ultrasound report that said, like everything's good in the hood, you might be like, well, okay, it's fine, right? So I think this is a good case where you have the pretest and you think, well, look, is this opinion good enough that I still don't think it's a concern? And obviously I still felt that it was a concern.
Yeah.
And again, like, just nice to have that kind of multi-system perspective where you've found this, what looks to be the source of sepsis, but also, a chance to actually assess the heart and lungs and really kind of see whether or not those add and how those impact the clinical picture. So great case, Laz. Thanks for sharing that.
Thank you.
Excellent. Obviously, you guys are doing great, I think, for time here, given that we started a bit late. Again, I apologize. I had Zoom account switched on me. So, but why don't we get Leo up here? I think Leo's on the line.
Yeah, made it.
Perfect. Awesome. Thanks for joining us, man. Really appreciate it. I know you're a busy schedule.
Yeah, I think it's all. I seem to put out most of the fires while other people were talking, so hopefully we can keep this going. Yeah, I'm on service at the foot right now. Okay, so this, I'm mindful this isn't M&M rounds. That's not too much foreshadowing, but this has been something that's happened a bunch of times kind of over the past kind of 5-10 years. And I think is of interest to kind of running residency programs and just kind of being in a big system in general. I'll preface this that this is, well, the images are all from one case. There's kind of pieces that are borrowed from lots. Again, kind of trying to maximize anonymity, and that this isn't M&M rounds. And there's a lot of details that will obviously have been left out. Things ended up okay, but it was a bit of an adventure. So I think my big thought about the reason why I'm presenting this is because, we know that POCUS is great for mitigating a lot of hazards with procedures, but I just wonder if maybe we're adding some new hazards that we didn't initially know about. So we'll just talk like really briefly, confirming the evidence for paras and POCUS, or at least for ultrasound guidance. Quickly talk about the patient case, and then show some images, and we'll have hopefully a good discussion. Just a couple things about paracenteses. If you do a para on a patient with cirrhosis that comes into hospital, it's associated with reduction in mortality. That's why it's recommended for everybody, regardless of why they're here. That's probably not news. A couple other things is that, when you dig into all the amazing JAMA signs on whether or not a patient has ascites, I think there's a solid 25% false positive rate. And so if you start sticking needles into a false positive, you're clearly going to have a dry tap and maybe biopsy a cecum. while you're at it, which is definitely suboptimal. And then paracenteses are obviously very safe overall, with low risk of bleeding and infections and perforations, especially if you use ultrasound. So these are ultrasound guided numbers. And then I think just a couple things. So, here I put on this side. So, the success rate for a POCUS directed paracentesis is high, 95%, versus if you kind of use the landmark method in your physical exam to assume there's ascites, you're gonna have a lot of dry taps and a lot of danger, I would say. There was a nice long prospective study done by IR over many years at many sites, and this is and what they were comparing whether they also had guidance to not, because it was a site apparently that didn't. They found that ultrasound obviously has way less bleeding, and then if you use and then this is more in POCUS literature, but if you use color Doppler, you'll looking for those epigastric vessels, you'll further reduce bleeding, although technically this didn't meet significance because the bleeding risk is so low anyway. But it is practice at our site, if you're part of the POCUS service, to use color Doppler to look for those epigastrics that are not necessarily where you'd expect them, which I'm not gonna lie, if I hadn't been doing color Doppler, I probably would have stabbed a whole bunch of them by now. So quickly talking about our case. So as middle-aged patient, child PU, decompensated cirrhosis, abdominal pain, recurrent ascites. They actually didn't look that sick. In emerge, there was a paracentesis in the merge. It was fine. Initially it was a little bit bloody, but then, it cleared up. There weren't really any concerns. They still had a bit of ongoing abdominal pain after the 5 liters was drained. So I thought, okay, let's just make sure there's no SBP. They had a bit of an acute kidney injury. Let's just make sure there isn't anything else going on. They actually seemed really stable, and there was discussion about sending them home. Classic 7 a.m. handover or 7:30 a.m. handover phone call. The patient's hypotensive. Their labs came back at 60, and there's no IV abscess, which is awesome. Favorite place to be at Monday or midweek handover. So CVC was placed on the ward. They didn't have any overt blood loss, but obviously they're putting on for prophylactic for variceal bleed if that was the case. Type in screened. They had a dry CT abdo-pelvis looking for retroperitoneal hemorrhage or anything else because of their kidney injury. Couple interesting things. So on their exam or on their physical examination to be redone, the paracentesis site was a little unusual. So the physician's fingers here are at the costal margin, and you can see that the bandage with blood is significantly superior to it. And this is corroborated by the CT findings in the middle image, where you can see the air from the paracentesis site right by the ribs. And then obviously the pertinent finding on the rest of the scan was that there's hematocrit sign on the right side of the abdomen, same side as the tap. So their hemoglobin sucked and continued to suck after massive transfusion on the ward. This was obvious, looking back through some of the notes, this was clearly quite an issue because a ward isn't really staffed to have the nursing to provide this amount of transfusion, and they're actually managed by ICU nurses through most of the day, and then ultimately went to ICU for ongoing management. However, this issue came up. Gen-Surg is like, we don't really want to take a child PUC cirrhosis to the OR for what you think is bleeding in the belly, because things will be bad. They figured that we should just try to medically manage things. So then the next question would be, should we do a CT angiogram to try to see if they're an embolization candidate, keeping in mind that their creatinine has now over doubled, heading toward tripled their baseline. And one of the concerns is that they couldn't see any, even though the patient was presenting with overt bleeding. On the dry CT there wasn't really a good site. So do we risk cooking their kidneys in a cirrhotic patient to maybe have something that could be embolized, or do we try to manage them medically? So POCUS, maybe we can find ourselves a site. So the first investigation was, is there maybe a huge, what does the puncture site actually look like? And really over there, everything looked fine. There wasn't a hematoma. Much like it's a thoracentesis, the vessels are where they're supposed to be. So, presumably they weren't hit. On first screen of kind of the site looking kind of into where the needle track would have been, everything kind of looked fine. There wasn't anything too close. The kidney was 7 centimeters away. The liver was obviously a little bit closer on the superior edge, or on the cranial edge. The bowel was far away as well. And this is post 5 liters of removal. The thought, well, maybe was there like a liver laceration or something? So color Doppler over the liver just looked like liver with vessels. There wasn't anything clearly extruding out into the abdominal cavity. But then there was this little like triangle coming off of the kidney, which was a little bit bizarre. And looking at it kind of in the coronal plane, you can kind of see it separate from the liver, but kind of free floating in the abdominal fluid. You put color on it, looks a bit like a volcano. And this was probably the most convincing. So this kind of became looks like a challenging conversation with the team, because how much do you trust POCUS findings at the bedside, and are you really going to embolize their kidney? Looking like the intensivist didn't really believe this, but they ended up going to ICU and we're no longer kind of under the medical service. So the medicine was planning on actually looking for an embolization, and ICU wasn't so convinced. She ended up not getting IR or angio or embolized, and was just kind of transfused and stabilized kind of on her own, with addition of lots and lots of platelets and lots of factors, and eventually just kind of had resolution of her AKI.
I just want to thank the presenters for today. You guys did an excellent job. This was a phenomenal rounds.